Good afternoon, Mr. Dunlop, and good afternoon, Dr. Cunningham.
Good afternoon, my lord.
Good afternoon.
Good afternoon. Right, ready to go, Mr.
Yes.
Dunlop, when you're ready.
Thank you. And just for the benefit of your own records, my lord, the witness's reference number is SCI WT 0384 5 zeros and a 1. Good afternoon, Dr. Cunningham. You've provided a statement to the inquiry, that's correct, isn't it?
That's correct.
Yes. I wonder if you could speak up slightly, or hopefully by me saying this, the people in the back room may turn up the volume slightly, but you're slightly quiet. And can you provide us with your full name, please?
Yes, Gail Cunningham.
Thank you. And am I correct that you live on the Isle of Lewis in the Western Isles?
That's right.
And you tell us in paragraphs 5 and 6 of your statement that you're a doctor, a GP, working at a medical practice in Lewis, and that you've been practicing medicine for about 39 years, is that correct?
That's correct.
And we also read that you've been a GP on Lewis for the vast majority of your medical career, is that correct?
Yes.
And we see at paragraph 8 that you were working as a GP during the pandemic, and in paragraph 9 you tell us you were also involved in an organisation, am I correct, it's called Long-Term Conditions Hebrides?
That's correct.
Okay, and I think that was set up in 2018. Can you tell me what was the reason for setting that up?
Because there are many people with long-term conditions that need long-term support that is not available on the NHS. So it was set up by people. I had been running self-management courses, 8-week long courses, and many of the people following that felt that they needed longer-term support in self-management.
To put it into context, can you give us any particular medical conditions that the patient suffered from?
Yes, I mean, any physical or mental long-term conditions, so from things like anxiety, depression, stress, to arthritis, inflammatory conditions, autoimmune conditions, chronic fatigue.
So a combination of both what I might, in a layman's terms, call physical ailments and also mental health problems?
Absolutely.
Thank you.
And undiagnosed, so people who just have persistent symptoms without a diagnosis are welcome.
Okay. And we see in paragraph 11 that this, can I call it the long conditions group? Is that, can I call it that? Or?
Yes.
Yes. We see in paragraph 11 that the long conditions group went online from May 2020 and the demand increased hugely during the initial stages of the pandemic. What was fueling that extra demand?
Mostly mental health, mostly people feeling very anxious and stressed. And because it's for people with long-term conditions, the additional pressures and stress of the pandemic, often their own conditions, were worsening.
Okay. And as the pandemic progressed, were you starting to find that people were presenting with long COVID symptoms?
Yes, you know, certainly over the years, many of the people within the group have had COVID, and a significant number of them have had long COVID symptoms. Yes.
And maybe this is probably a point just to kind of jump in. And I think, regrettably, you caught COVID, which developed into long COVID during the pandemic. Is that correct?
Yes.
And when was that approximately?
I avoided COVID until February 2023, so just over a year ago.
And
I've symptoms since.
And my understanding is that long COVID is COVID symptoms that last over 12 weeks. Are your symptoms still continuing to date?
They are, yes.
Okay. And I suppose before we come back to your statement, how has that affected your ability to carry out your duty, or how has it affected you in your day-to-day life first?
You know, I live with long-term conditions, so I have a degree of daily symptoms anyway. Since COVID, I have more tiredness, you know, greater fatigue. You know, I will generally have to rest every day for several hours. I have breathlessness. I have increased chronic pain.
And do you know,
to long COVID.
we heard earlier today from a GP in the Central Belt who contracted long COVID whilst in the course of her employment as a GP. Do you know how you contracted COVID, which led to... No.
I have been working remotely, so mine was through community.
Okay, thank you. Moving back to your statement, at paragraph 16, you discuss your GP medical practice and that the population in Lewis is more elderly than average. You tell us that during COVID, the practice continued to take blood tests and blood pressure tests. If you can move forward to paragraphs 42 and 43.
Yep.
You identify some services that, medical services that stopped, and we see it, just correct me if it may be easier for me to read them out, but you say, paragraph 42, cervical screening stopped, I believe. I know the breast screening unit had been here not too long before lockdown, but I think I'm right in saying that breast screening also stopped for a while. I think they only returned just this year in 2023. And at paragraph 43, you say, we only had minimal contact for women who needed pregnancy antenatal care. Most of that is done at the hospital. Patients might come in here for confirmation of pregnancy, but that's really it. So the blood tests were continuing, but these services were not ongoing.
So the cervical screening stopped for several months at the beginning of the pandemic. My understanding is in the practice it restarted by the summer, by July 2020. Right. We restarted doing the cervical screening. The breast screening is only done intermittently anyway. So the unit only comes to the island, usually every 3 years.
Right.
It's just before the pandemic, so there wasn't a much longer gap than usual.
And you tell us at paragraphs 39 and 40 that patients with chronic conditions were not being monitored and that some people's health declined because of this. Do you have examples, without naming any individuals, do you have examples of people whose health declined as a result of the failure, not the failure, but the inability to monitor the health of those patients?
So I think what I've said here is, I think it's fair to say that patients not being monitored during that time would not have helped their condition. So some people's health may have declined. Some of that is through, the monitoring, but a lot of that was through lockdown and people not being able to exercise and possibly not sticking to their diet as well. For our chronic disease monitoring, it did stop again for a few months at the beginning of the pandemic. It restarted by telephone in the June of 2020. The service was, almost normalised by the summer 2022, when we were offering either face-to-face or telephone review. But it has taken a while for that to get, for the backlog to be completely cleared and for us to be completely up to date with the chronic disease monitoring.
I suppose the point I was trying to make, maybe poorly, was that, and I perhaps was misunderstanding you, you've said people's conditions may have worsened. I was just wondering if you knew of any concrete examples of where that had happened.
No.
No, okay.
Because of the way that I've been working, latterly I've been doing mostly mental health work in the practice.
Well, I wonder if we can talk about the mental health work that you've been doing. In terms of mental health, did you see an increase in patients presenting with mental health problems at the outset of the pandemic?
Absolutely, yes. At the outset and throughout.
Okay. And was that a range of ages, or did there, before the pandemic, when you had patients with mental health problems, were they of a particular age group?
We would see people of all ages, but it was predominantly middle-aged people. I think once the pandemic came in, you know, within numbers of months, we were seeing more and more younger people, and numbers of them were even in their teens, with significant, usually anxiety, but sometimes depression. The numbers of people with mental health conditions had been increasing slowly pre-pandemic, but there was a fairly dramatic increase.
And I think you deal with this. There's a chapter in mental health starting at paragraph 74 in your statement, and you say at paragraph 75 to 77 that there was a shift from middle-aged to younger people who were suffering mental health problems. I mean, you mentioned anxiety. What was the root cause of that anxiety? Was it the inability to get out and about? Was it what in particular was causing the anxiety?
I mean, a huge range of things. So some of it was, you know, people being anxious about the virus itself and the effect it might have on their health and their livelihood. But a lot of the youngsters, I think it was the effects of the lockdown, you know, not being able to socialise. You know, people having their schooling disrupted, the university disrupted.
Have those conditions, in those patients that presented, the younger ones I'm more interested in at the moment, those younger patients that presented themselves in the, I'll say the first few months of the pandemic, are you still seeing them because of continuing mental health problems? Or are they still seeing medical practitioners as a result of continuing mental health problems?
I would imagine that, you know, some of them that engaged during the pandemic will still be under the care of mental health professionals, yes, or the GP. Mm-hmm.
Okay. And in terms of, we've discussed these younger patients having mental health problems caused by lockdown restrictions. What was the availability of mental health medical services and support like in Isle of Lewis at that time, at the beginning of the pandemic?
You know, we did have services. Most of it was being carried out remotely, so a lot of it was in telephone. My understanding is that they may very well have visited some people and probably increasing numbers of people at home as the you know, as things continued.
And you say most of it was done remotely. Would it have been done remotely before the pandemic?
No, I don't. Not that I'm aware. You know, I think there may have been times when they would do reviews on by telephone, but first contact. My understanding is that usually the community health service used to see people face to face.
And is that because it's more effective to assess someone's mental health problems if you are face to face?
I would say so, yes.
Okay.
It's also easier to build rapport, which is so important.
You also tell us that suicidal thoughts amongst young people was increasing. Again, was that due to COVID?
You know, it's difficult to say, but it became, you know, really very marked during the pandemic. Prior to the to COVID-19 pandemic, I would maybe see somebody who was expressing suicidal ideas once a month, whereas during the pandemic, that had increased dramatically, and sometimes every week somebody was saying that they were feeling suicidal. Often they were young, in their teens or 20s.
And did they indicate what was causing them to have this suicidal ideation?
I mean, usually it's multifactorial.
And I'm not trying to speak about any individual patients. I'm just wondering, obviously this inquiry is concerned with the impacts of COVID. I'm wondering whether one of those factors was anything that had anything to do with the lockdown or the restrictions or anything that arose out of the pandemic.
I'm sure that would be a significant factor for most of these people, yes.
And you tell us at paragraph 80 that the waiting list for mental health has increased. And is that a combination, sorry, is that due to increased mental health problems or the backlog in the NHS or a combination of both?
It'll be a combination of both, but certainly there is a bigger burden of mental health. You know, my understanding is that in numbers of areas, if not all areas of the NHS, staffing post-pandemic has been even more difficult than it was before. So people, you know, posts that become vacant, not being replaced, not being able to be replaced, or people, I think the people are less resilient. People are tired, the NHS workers. So I think there is greater sick leave in almost every area.
And is that, are you talking about primary and secondary care, or?
Certainly primary care. Primary care and community. You know, if we're talking about mental health team, that's community.
Okay. And going back to your statement, I suppose, going back, because we were looking at the chapter on mental health, I think before we looked at that, we were back at, well, if we look at paragraph 27, you tell us about infection control purposes and that the practice had to be changed, and you describe various things being done, such as vinyl floors being laid over carpets in areas and the practice being sectioned off. To what extent did those changes enable the practice to, I won't say operate as normal, but operate as normal as it possibly could, given the circumstances of the pandemic?
Yes, I mean, we always remained open. We always remained available for patients who wanted to come in to be seen face to face. But yes, as I said in my statement, you know, our practices had to change. You know, we're lucky that we're a relatively small practice, so we can be quite quickly adaptable.
And you're a small practice, but presumably there's a number of other practices in the general area. Whereabouts in Isle of Lewis are you based?
Stornoway.
Okay. So there'll be other GP practices in Stornoway, presumably?
Yes, there are two
Yes.
practices based in Stornoway that cover, you know, most of the east of the island, and there's one more practice that covers rural Lewis, mostly to the west.
Okay. And you tell us at paragraph 32 that the patients were happy with remote contact with their GP, and you've already told us in your statement that there was a greater proportion of elderly patients. When there did have to be remote contact, did IT cause any issues given the proportion of elderly patients?
So remote contact, a lot of the patients were quite happy with telephone contact.
Right.
The near me video consultations was much more problematic.
In what respects?
I think just people not used to using the technology, particularly the older generation. And, you know, in general, when I moved to remote working, I had the option of using Near Me, but I would tend to rely on telephone consultations.
And what about the GPs themselves, people like you? Was the GP practice up and, you know, was it ready to go digital, so to speak?
We were lucky in that our lead GP is very IT literate, and he was already using remote means. So our changeover to working remotely was relatively smooth and relatively well supported.
Thank you. Moving on to paragraph 33, you tell us that the out-of-hours service continued through the pandemic. And if I'm understanding correctly, in paragraph 32, going back one, you're saying that you're telling us in your statement that patients with, and correct me if I'm wrong, because maybe I've picked this up wrong, does paragraph 32, it suggests to me that patients with symptoms of COVID were sent to an assessment unit at Stornoway Hospital. Is that correct?
So initially, they would all be coming to the practice. Everybody was coming to the practice.
And when you say initially, just so I can put that into context, what dates are we talking about, roughly?
Roughly the first few months.
Right. And after the first few months, they were going somewhere else?
Yeah, public health set up an acute assessment unit at the hospital so that everybody who had was suspected of having COVID was assessed up at the hospital.
And is that the hospital for the whole of, I think I've been over to the island, but the Isle of Lewis and the Isle of Harris, essentially, it's one landmass, albeit that they're described as the Isle of Harris and the Isle of Lewis. So if I talk about that one landmass, was that everyone in Harris and Lewis going to Stornoway?
Yes.
And you'll be able to help me better than my recollection, but I mean, in terms of distances, what kind of distances would people maybe having to travel? Up to 100 miles or not as much as that?
75 anyway, from some of the people in the very south of Harris.
Okay. And was that for everyone, even if they had mild symptoms?
I mean, there was a team that could be called out. So, you know, people in and around the town area were encouraged to go to the hospital. Others, you know, particularly if they were ill or I'm not involved with on call, but I would guess that the team would cover people who were in the outlying areas. The community team that went out to assess would have covered these people in the very outlying areas.
Okay, thank you. And I mean, just sticking with the difference between, I suppose, somebody that's requiring treatment in a city centre in the central belt compared to an island like the Isle of Lewis. I mean, you discussed the differences at paragraph 87 of your statement, and you first identify that there were no ICU facilities on the island, although there were ventilators available during the pandemic. Did all hospital patients who needed a ventilator get access to a ventilator? Was there any shortage that you were aware of?
Not that I was aware of, but you know, with not being involved with secondary care, but I was never aware of there being any shortage of ventilators. I mean, we do have a small high dependency unit that runs all the time that has the opportunity of 3 ventilators in it. But I am aware that the health board got further ventilators and adapted a separate area just in case there was extra need.
And you tell us in paragraph 89 that patients required to be transferred from the island to ICU. How was that actually, where did they go and how was that done?
You know, again, that's all secondary care, but it would be through the hospital in contact with hospitals in the mainland. They usually go to Glasgow, but sometimes if the ICUs in Glasgow are full, they do go out. You know, I know they often use Paisley as well.
Okay. And I think you mentioned that in your statement at paragraph 90 that patients having to go to Glasgow ICU. During the pandemic, if someone from the island had to go to ICU, or maybe it's the same before the pandemic, how would they actually get there? Would it be an ambulance? Would it be lifted by an air ambulance? Would it?
The air ambulance.
Sorry?
Air ambulance.
Air ambulance. And those patients that required to go to, and I'll just say Glasgow, whether it's Glasgow or Paisley, I don't think it really matters for the purpose of my question. How would family members be restricted essentially from visiting them when at the early stages of the pandemic if they were based on the island, the Isle of Lewis?
I think there were restrictions everywhere on family visiting, but you know, it did make it much more stressful for family members if their, beloved family member with COVID was on the mainland and very ill.
You mention in paragraph 92 of your statement that the island generally relies on locum support. Did that place any particular pressures given the difficulties in bringing people to the island during lockdown?
I'm sure it made it all even more problematic than it is already. I'm not aware of any critical instance that occurred from it, but I think it'd be fair to say that it was more challenging to bring locums on.
And in the next paragraph, sorry.
In the initial few weeks. But locums were coming and going.
And in paragraph 32, in the next paragraph, you state that as far as you were aware, there were no particular issues with PPE and that there was a decent supply.
Yes, that's my understanding.
Can you remember what kind of masks you were supplied with?
The normal surgical masks, often called the surgical masks.
And in terms of
doctors were tested for the fancy FP3s as well.
Sorry, it's entirely my fault. Sorry, you said I heard you mentioning the masks, but you said you were tested for. Did you say?
I think we all got. I think all the doctors, probably all the clinicians that were likely to be in face-to-face contact with COVID positive people at the beginning of the pandemic did get FP3 testing and supply of those masks. But in general, what people were using was just the normal surgical masks. That was the standard.
And living on an island, were there any particular difficulties caused by pharmaceutical supplies being delivered as normal?
I am aware that with the initial vaccines, the ones that had to be frozen or deep chilled, there was some concern, particularly with taking that down to the Southern Isles, because I think there were restrictions in them being able to be flown, and there were concerns. I don't think at the end of the day, I think they managed to work around the concerns, and the whole of the vaccination rollout went very smoothly from what I can gather.
Oh, just dealing with the vaccination rollout going very smoothly. In terms of, I know just from my own personal experience, how it operated in the Central Belt. In terms of the Isle of Lewis, was there a single vaccination centre or was there a number dotted round the island?
There were a number.
There were a number. And in terms of, could patients be vaccinated in their home if required?
Yes.
Yeah, okay. Were you involved in the delivery of the administration of the vaccination? No. Okay. I mean, largely, your statements, notwithstanding obviously the effects of the pandemic, you're relatively positive about how things happen in the island. Indeed, in paragraph 95, you talk about the communities rallying around together in each village, arranging a WhatsApp group to enable deliveries of groceries and medication. So maybe that probably comes back to my first question. Putting aside the vaccines, were there any issues with ferries that kind of caused difficulty in delivering medical care?
No, I mean, no more difficulties than we usually have with the ferries and the weather. No, I don't think there were any greater difficulty here.
Okay. Moving on to paragraph 99 of your statement, you tell us that visiting care homes wasn't one of your duties, but do you know if your colleague GPs were still visiting care homes at the early stage of the pandemic?
In the very early stages, they were, and then there were another system was put in place where it was either specialist nurses or advanced nurse practitioners were part of their remit was to cover the care homes, and they would then, deal with anything that was within their capability. And if it wasn't, they would liaise with the GPs rather than different GPs traipsing in and out of the home.
And was that to free up the GPs, or was that to ensure that there was one person only going in and out?
Both, but certainly, infection awareness was a big part of that.
I mean, just generally, did you notice a discernible change in the level of service provided by GP practices during the pandemic?
I mean, our practice remained open right through, and I think the service was always there. The patients were very mindful of the recommendations, and the call rate into the practice plummeted for the first numbers of weeks of the pandemic. And it really took several months for the demand to come back up. So often the patients were thinking, oh, well, the practice is busy with people that are in greater need than I am.
We discussed vaccines earlier and the difficulty, I think it was the Pfizer one that had to be kept at a low temperature. And you mentioned that at paragraph 107 of your precognition. I'm just wondering whether that difficulty to keep, and I think you said it was overcome, but correct me if I'm wrong, did the requirement to keep certain vaccines at low temperature reduce the choice of vaccines available to people in Ireland?
I don't know, but I would guess so.
Moving on, I suppose, back to long COVID, paragraph 115, you say you were part of the steering group that set up the long COVID service here, and by here, do you mean the Isle of Lewis, I take it? Yes. And who was represented in that steering group? Do you remember? What bodies, I meant, sorry, not individuals' names.
There was, representation from the hospital sector, the primary care, your allied health professionals were part of that, the physios, the OTs. There were, myself as a GP, but also representing long-term condition Hebrides. I think Chest Heart and Stroke Scotland also had representation on it.
And what was the purpose of that long COVID service? I know it was shelved before it ever got anywhere, but we know that from your statement, but what was the purpose of it when it was initially to be set up?
It was set up to do assessment and support for people with long COVID. Okay.
And I understand from your statement that never, it was shelved, I think is the word you use, is that? Why? Do you know why it was shelved?
Why? I can't say, but it was. It certainly appeared to be up and ready to go.
And well, do you think it was the right decision to shelf it?
No, I think that there are still quite a lot of people living and struggling with long COVID, as there are people struggling with all sorts of post-viral fatigue syndrome. And my hope had always been that if the long COVID service could be set up, that it could then be widened to include people with other post-viral symptoms.
We talked, when we started speaking, we talked about the long-term conditions group, I think. Is it essentially stepping into the gap left by shelving the long COVID?
Yes, and many of our members have issues with long COVID, and the work that we do certainly helps them manage their symptoms, yes.
And are there facilities on the island for people to receive treatment for long COVID, or do they usually have to go to the mainland?
Where I saw the service, the long COVID service stepping in, was for people with the vaguer symptoms. People with more significant symptoms, cardiac symptoms or respiratory symptoms, will have been and will continue to be seen by our specialist respiratory physicians, or will be referred over to a cardiologist specialist in the mainland. But the vaguer symptoms, things like brain fog, fatigue, diffuse chronic pain, they're not managed terribly well with standard services.
And I think you identify that in your statement. You say at paragraph 117 is that your view that long COVID can essentially be dissected into component parts, some of which are vague, such as brain fog, and it's those more vague symptoms that there's a gap in the treatment options.
Yes.
How, in your opinion, should that be addressed?
Certainly a long COVID service on the island would certainly go some way to addressing it. At the moment, it's organisations, voluntary organisations like Long-Term Condition Hebrides or Chest, Heart and Stroke Scotland. I believe they run a long COVID service as well to support people that are needing support and, tips and self-management.
Paragraph 119 of your statement, you tell us that overall, I think you were happy with the strategic decisions that were made by the Scottish Government at the time, and that the guidance issued was generally clear. But you go on to make some criticisms after that. In paragraph 120, you ponder whether lockdown was in everyone's best interests. What do you mean by that?
Well, I think, as I said before, that the levels of health issues, particularly mental health issues, that I believe are at least in part due to the prolonged and repeated lockdowns.
And that could have been avoided if the lockdowns hadn't been so, if they hadn't been so severe. Is that what you're suggesting?
What I'm suggesting is I think it all needs to be looked at and, scientifically examined, and what were the risks, what were the benefits, what should we do in a future pandemic? What would be to the best of the population?
At paragraph 123, you identify that information from the Scottish Government and Public Health Scotland wasn't being updated regularly enough, in your opinion, and you give examples, one of which is that the symptoms of the emerging variants were not updated. You go on to say in paragraph 124 that the UK Zoe study was much more up to date than the government. And by the Zoe study, what do you mean by that?
It's a study, possibly in Oxford, down in England. It had been running for several years before the pandemic, and I believe they had several thousand people on a database. And they produced an app fairly early on in the pandemic where these several thousand people could offer in their symptoms. And very quickly, I believe, it grew and had a whole wealth of data coming in, which was then analysed by the team. I think Dr. Tim Spector is the lead for it. And I certainly found that I got more up-to-date information from their videos on YouTube that would give you the percentages of symptoms that you were were happening in their several thousand population, and the rates at which that they would be occurring in COVID positive people.
Thank you. And I think you mentioned the UK Zoe study in more detail in paragraph 124. Just coming to the end of your evidence, but in paragraph 126, you discuss the remote working carried out at your medical practice. I'm just wondering, has the practice, and I appreciate you told us that your practice was open for business throughout the pandemic, but the level of remote, whether that be by telephone or any other form of digital consultation, has that remained the same, or has it reduced as we've come out the pandemic?
So it's certainly reduced since we've come out the pandemic. Pre-pandemic there was some work was done by phone, but most of it was face-to-face. I would say that we now offer patients the choice, because there are many patients that find it preferable to have a telephone consultation or a video link. So we're now using mixed methods.
And just finally, I suppose, is there anything else, at the end of your statement, is there anything else you'd like to add, or that you think that I haven't covered in your statement, before I thank you for your time today?
I suppose a couple of things that I'm very interested in is, the excess death rates, and any research that is going into why we should have excess death rates post-pandemic. I guess the other thing that I'm also very interested in is the vaccines and the vaccine injury that we know happens with any vaccine. I think it would be really helpful for us to be very clear about what the risks are, and bear that in mind if we are producing any more mRNA vaccines, just to be very, very clear about the safety profile of the ones that we're using at this time.
Well, thank you, Doctor. I don't have any further questions for you. Melissa, I don't have any further questions for this witness.
Thank you, Dr. Cunningham. Just for your information, the second last thing you said, excess death rates, I've been wondering about that for a while, and only about 10 days ago, I asked some of our research team to not only dig out statistics, but to pry into the statistics to see if we can get to the bottom of that. So it's something that I'll be looking at fairly carefully in the months or possibly years ahead. I hope you think we get the right answers when we get the results on it, but thank you for your evidence. I'm very grateful.
Thank you very much.
Thank you.
Good. Now, Mr. Dunlop, I'm in the happy position of telling you that your next witness is ready for 2:15 if you're happy to start at 2:15.
Absolutely, absolutely. It's a Friday, so.
That's very sensible. Thank you.
Thank you, my lord.
Good. 2:15. Now, good afternoon again, Mr Dunlop.
Good afternoon, my lord. The last witness today is Mrs Purchase, and the witness statement number is SCI WT 0419 5 zeros and a 1.
Thank you. Good afternoon, Mrs Purchase.
Good afternoon, Lord Brailsford.
Very good. Now, when Mr Dunlop's ready, he'll ask you some questions.
Thank you, my lord. Good afternoon, Mrs Purchase, and you've provided a statement to the inquiry, is that correct?
Yes, it is.
Yes, and we see that is your full name shown in that, Fiona Margaret Purchase?
Yes, that's right.
And I think in preparing for today's hearing, you've noticed a couple of errors in your statement. I wonder if I can take you to what I understand to be the first error. If we look at paragraph 9.
Yes.
I'm just looking at the one that's on the screen
yes.
to make sure. And we see that it says, and Claire Cairns is one of the witnesses to the inquiry. That's why she's named. As we've explained, we don't normally name individuals. You say that at some time in 2021, I was approached by Claire Cairns to be part of the care group, as I'm going to call it. I understand it was, and please don't say the person's name, but it wasn't Claire Cairns. It was another individual. Is that correct?
Yes, that's correct. It was another representative of the coalition of carers, but it wasn't Claire.
And I think the other error was at a date. Can you?
Yeah, that was paragraph 13, and the first meeting that we attended of the Pandemic Response Adult Social Care Group wasn't the 28th of October 2021. It was actually the 23rd of September 2021.
27th of September.
23rd of September.
Thank you. But other than those two, I'll call them typos, everything else was in order.
Yes, that's right.
Yeah, thank you. Well, I wonder then we'll just start, maybe just go through the statement. I've got a few questions for you. We'll just go through it in the order that it runs. We see at paragraph 1 that prior to retiring you were a senior social worker. When did you retire, approximately?
I retired in August 2020.
Okay. And without naming him, do you live with your husband?
Yes, I do.
Okay. And does anyone else live in your house other than you and your husband?
Well, at that time...
Without naming anyone, sorry, just to make... Yeah.
Yeah, at that time it was just ourselves. Yeah, that's right.
And when you say at that time, sorry, maybe just so that the period we're particularly interested in is just immediately before the pandemic in March 2020, and then from March 2020 through to the end of 2022. During that period, was it just you and your husband in the house, or were there any other people?
Yeah, well, our daughter moved out to protect my husband because she was working, and our son moved in again, really to be part of the, I can't remember what you call it, you know, that kind of grouping that you were allowed to have.
Bubble.
That's it.
Yep.
To offer some support to us.
Okay. And dealing with your husband, does your husband suffer from any medical conditions?
Yeah, my husband has advanced Parkinson's, and he was diagnosed almost 30 years ago, so he was young when he was diagnosed. He was just 41, and his condition, obviously, it's progressive, so his condition is very advanced now than it was throughout the pandemic.
I know, I suppose that was my question. At the outset of the pandemic, in March 2020, did your husband require a carer?
Yes, he had a personal assistant. It was just for 12 hours a week, and at that time that was enabling me to keep working, because she would come in and make sure that he was, you know, he had his lunch and had some support during the week, and you know, as part of that support that enabled me. I was still working full time at that time.
And you say working full time. You told us that you retired, I think, in August 2020. Was that correct?
It was, yeah. I hadn't intended to retire. I took early retirement really because, well, first of all, I was working from home, really because of my husband's vulnerability. But at the very beginning of the pandemic, it was that initial week really, when everybody knew that the risks were high, but there still hadn't been, you know, word to work from home or to lock down or, you know, take precautions. So everybody knew that the risks were high. So I was first of all given agreement to work from home, and I was told by my husband's Parkinson's nurse that we should be shielding. and we stopped the personal assistant coming in to protect him. And then the following week, I was required to go back into the office, but felt I couldn't safely go back into the office because of the risk. So that was a really difficult period for us, as you can imagine. And trying to work from home. Well, I didn't go back into the office, and a few days later, everybody was working from home. But that was quite dramatic. And then he had a number of falls because I was trying to work from home in one room, and he was trying to manage in another room. So he had some quite serious falls. So really, I decided that early retirement was what I had to do at that point.
Would you have, or maybe you can't answer this question, but was the early retirement indirectly caused by the pandemic, insofar as it caused you to have a change of work and it caused there to be less services available to your husband?
Yeah, I think I would safely say that it was directly caused by the pandemic.
Okay.
Because it resulted in all of that. It resulted in us having to say to the personal assistant not to come in and having no support. And because of all that difficulty about work, and because of his declining health and the falls that he had, and that was really all a result of the pandemic. I hadn't intended to retire early at all, because we had, working in the local authority, I had the option to reduce my hours and really to start drawing a pension but still working, and that's what I had in mind as my retirement plan, to gradually retire. So there was a financial cost to that as well.
Of course. And in terms of your evidence before us today, I suppose it's not largely, it's helpful as a background to know a bit about your husband, because that kind of led you, I suppose, into your charitable work with these organisations that we'll talk about this afternoon. And the organisation to be spoken of is Pandemic Response Adult Social Care Group, PRASCG. And if you don't mind, I'll just refer to that as a care group. It's quite a mouthful for me. And please tell us, what is the care group? What is it and what does it do?
Well, it had been meeting before we joined it, and my understanding was that it was a follow-on to the Care Home Rapid Action group, and really my understanding of the Pandemic Response Adult Social Care Group, it trips on my tongue because I've said it too often. It was a group really to bring together. It's probably helpful if you don't mind if I just refer to something about it. It was a success of the Care Homes Rapid Action Group, and it was a multi-stakeholder focal point for the work being undertaken to support the effective delivery of adult social care. So it brought together a whole range of people. There were about, I think, 60 people on the invitation list for the group, from a wide variety of organisations, and COSLA from the Scottish Government, and from the third sector. And it was really to share information about risks really from the pandemic, risks from preventing the recovery from the pandemic. I thought it was going to be more of a decision-making group, but I think from my experience, it was more of that awareness raising, sharing information, and raising issues where it was clear that issues needed to be raised to COSLA, to the Scottish Government, or to the Gold Group. And we had a bit more about the Gold Group as the group progressed, and there was a representative from the Gold Group, the Gold Social Care Group, came to that group and presented. So it linked with quite a number of bodies, and it brought together a large number of agencies, and it was really a lot about information sharing.
Okay. Sorry.
Yeah, and raising the profile of risks as they became more apparent.
And I think that's not the only organisation you're involved in. You tell us in your statement that you're involved with the Scottish Coalition of Carers, and maybe you can just tell us briefly what the Coalition of Carers do. And I'll maybe refer to it as the Coalition if you don't mind. But what does it briefly do? Can you tell us?
Well, it covers Scotland. It's a small organisation, but it's very much about raising the issues on behalf of carers, bringing together carers. It's links with the Scottish Government. It's a high-profile group, and it's an influential group, I found, and I became involved really because really because I was campaigning about the charging policy for my husband's care and charging for non-residential social care support and the injustice of that. And I found that the Coalition of Carers was an organisation that was really championing that issue as well. And they had a group called the Carers Collaborative Group, which brought together around 12 carers regularly each month to discuss issues and raise issues and campaign. So I became involved with the Carers Collaborative, and it was through that I was asked to join the Pandemic Response Adult Social Care Group, because the group, I think, decided to involve unpaid carers in the group to make it more representative.
But they're separate, they're separate organisations?
Yeah, separate organisations, yeah, totally separate. And but the Coalition of Carers is a member of the Pandemic Response Adult Social Care Group. So I think they were asked about involving, I think initially it was one unpaid carer, and then it was 2 unpaid carers, and then 3 of us from the Carers Collaborative were invited to join. And I think that the thinking had been that if one of us couldn't attend, then there would be 2 people to attend. But as it turned out, 3 of us attended the first meeting, and we just kept attending, and nobody stopped us. So, so we had 3 representatives on the Pandemic Response Adult Social Care Group from the Coalition of Carers. Thank you.
And you discuss the care group from paragraph 10 of your statement, and you tell us at paragraph 11, during the pandemic, you attended various meetings of the care group. Can you tell us what, and I suppose you can name these bodies, what bodies were represented at the care group meetings?
Well, it was jointly chaired by COSLA and the Scottish Government, so that tended to alternate. So there would be a COSLA chair and then a Scottish Government chair. There was a big long list of organisations attending. Many there was SSSC, Coalition of Carers, Carers Scotland. I would need to go back to.
I could describe them as heavyweights in the carers' decision-making process. Scottish Government, COSLA, Coalition of Carers, Scottish. I mean, in terms of what type of issues were discussed at these meetings, I mean, maybe you can give us 2 or 3 examples.
Yeah, it was very broad-ranging. It was things like the vaccination strategy. We'd get updates about the vaccination strategy and updates about the latest decisions that the Scottish Government was making about the pandemic response.
Can I cut in there? When you say updates, was it were there decisions made at these meetings, or was it a kind of, you know, a chit chat about what was happening, or was there actually something that had to be decided at the meetings?
There were sometimes action points from the group. Very often we'd have a representative from the Gold Group who would come and present us with quite a lot of stats about things like the vaccination strategy, or about COVID rates and what was happening in care homes and that kind of thing. So there's a lot of information sharing, but sometimes from the discussion in the group, there would be an action point. For example, one of the carer representatives was keen to know about the extent to which day centres and community supports were actually opening, because we were getting feedback that, you know, that agreement had been given to say day centres opening, but actually the reality on the ground was that very often they either hadn't opened, or they'd only opened partially, or staffing levels wouldn't allow them to open because staff were being deployed elsewhere. And so it was really hard to get information about actually what was, you know, it sounded fine, you know, to say, well, it's agreement's been given to day centres opening, but when the reality on the ground is that they haven't opened very much, but there wasn't a clarity about the extent to which they'd opened. So an action point had been to try and establish to what extent day centres had opened.
And can I use that as an example in a question?
Yeah.
So if using that example, you're at a meeting which is represented by some heavyweights, the Scottish Government, COSLA and other groups we've talked about, and it comes to light during these discussions that these day centres aren't open, and it's the suggestion is that they are. What gets done at the meeting, using that as an example? Does that get fed back so that there's you talked about an action point or an action plan. So does something get done about that?
Yeah, we found that quite a frustrating issue actually to follow, because by the next meeting where we're expecting to get some feedback about that, there wasn't feedback, and actually it seemed very difficult to get that information, because it doesn't seem to exist anywhere. And in the course of, well, I suppose alongside our involvement in the Pandemic Response Adult Social Care Group, we were still attending the Coalition of Carers collaborative meetings. And through that, through those meetings, we were offered the opportunity to meet with the Cabinet Secretary at the time. And it wasn't just us three carers who were on the Pandemic Response Group, it was the 12 or so carers from the Carers Collaborative. So we had the chance to raise that issue as one of the issues that we had with the Cabinet Secretary. And he said that he would find out. And we found that when through the Pandemic Response Group, when we didn't have the answer to that, and we pursued that further, then we were told, well, a number of carers had met with the Cabinet Secretary and he's asked for that information, so it'll likely come through that route. And eventually we got information back that showed that that the day centres, many of them had only partially opened or hadn't opened. But it was really, really difficult to get that information, and it just didn't seem to exist anywhere. And I think actually the information only came through the discussion with the Cabinet Secretary through the Coalition of Carers, rather than us raising it in the Pandemic Response Group.
And in terms of the information, just dealing with the care group meetings, the information that would be fed back, you were looking generally for information to come back from the Scottish Government, and that information wasn't coming back. Is that a fair summary?
Yes, and I think it just didn't exist anywhere either. I think a simple way might have been to ask health and social care partnerships to provide that information, but it just seemed that the questions weren't being asked, or the information didn't exist, or it seemed to take an inordinately long time.
Can I ask, were there minutes of these meetings?
Yes, there were minutes.
Right. And we would be able to, presumably the inquiry could get hold of those minutes if required?
Yes.
And would you be able to help us with those minutes?
Yes, they were emailed out to us, so I would be able to go back in my emails and get them.
We won't dwell on that today, but that might be something that the inquiry staff, if you'd be kind enough to help them with, that might be useful. Looking at paragraph 12 of your statement, you say some of the issues included the vaccination strategy and the winter preparedness strategy, and those were discussed. And we also see at paragraph 14 of your statement that unpaid carers was a standing item on the care group agenda at meetings. Why was unpaid carers deemed sufficiently important to be a standing item?
Well, I think the first meeting we went to, which was the 23rd of September, we just got the agenda that day for that meeting, and I think that there probably wasn't very much of an expectation that we'd be attending that meeting, because we'd just been invited to join, and then we got the agenda, and it was after that we met the leads of the Pandemic Response Group to discuss our involvement. So I think we rather not so much gate crashed the meeting, but we weren't really expected. But as carers, we were pretty vocal, I think, about the issues that we were experiencing and that we knew other carers were experiencing. And so I think that raised the profile of carers' issues within those meetings. And then by the following meeting, it was, by the following meeting, what had happened was that, because in the first meeting, the winter preparedness strategy was presented, it was in draft form, and we were asked for comments. And we very quickly, as a threesome of carers, put together comments. We actually, we gave comments on the 23rd of September as we were looking at it, but we met on the 27th of September, and we gave quite detailed comments. You know, we met and we discussed it and we put together detailed comments, and we got them sent in that day. So that was just 4 days after the initial meeting. But by the following meeting, we found that the winter strategy had gone out and that none of our comments had been included. We felt nothing that we had to say had really influenced that. And it made us really very frustrated. and we were told that there hadn't been time to take into account our comments. So, so there was to be further discussion. Well, a representative of the carers policy team who's on the pandemic response group wasn't, I think, there that day, but he was invited to, suggested he would be there by the following meeting, and that we could meet with him. So I think that raised the profile of carers issues, and from that it was decided that carers issues should be a standing item on the pandemic response group.
And I think we see that all discussed in your statement. There's comments to the vaccine strategy, there's comments about the winter preparedness strategy, and I think there's comments about the winter preparedness plan, and I think the plan and the strategy, are they different? Am I correct?
Well, I think they were pretty much the same. There was a draft strategy, and then it turned into the strategy plan, but I think one and the same. And
I think, as you identified, the main item in one of the meetings was the draft adult social care winter preparedness plan. It was circulated for comments. The care groups quickly sent extensive comments. However, none of these comments reflected in the published plan. We were told that there'd been insufficient time, and I think you said that you did it very quickly. Do you think they were just paying lip service to what you were?
Well, that's what it felt like to us at that time, and I think too, because having had that experience of 36 years in social work in a local authority and in a management position, I was used to contributing to policy documents and so on, and having that taken into account. So finding ourselves, because we weren't being paid for this, we were there as unpaid carers, and everybody else around that table was being paid for their time. We weren't. Mm-hmm. But happy to have the opportunity to be involved. But we devoted quite a lot of time to putting together our thoughts and contributing. So it did feel a bit of a slap in the face, really, not to have our comments taken into account. But I think that was recognised to an extent, and there was then further discussion with the carers policy team, because at that time we were really highlighting the need for a carer recovery plan, and the carers policy team told us that the Minister for Mental Wellbeing and Social Care at the time had decided to develop a standalone carer recovery plan, and that we could contribute to that. And one of the suggestions we'd made about the winter strategy was that there should be urgently a sum of money. Well, we were suggesting about 5 million given to carer centres to support the urgent needs that so many carers had at that time. Because by that time so many carers it was very traumatic for many carers, but also they were providing a lot of care without support, and they were in need of urgent support. So we suggested a budget of around 5 million, and not long after that, actually, we were told through the carers policy team that a decision had been made to allocate £4 million for that support, and actually we were given the credit for that through raising the issue of the need for the support through the pandemic response group. So there was something came out of it, but not to the way that we had.
Yeah, I think we see that in your statement, because you deal with that at paragraph 21. You identify that £4 million of funding was made available for urgent support to carer organisations, and just in very brief terms, what was that funding to be used for?
Well, really, it was for carers support centres to offer directly to carers with urgent need. So the idea was, well, I'm not sure how it was all delivered in every area, but it went to carers centres, I think, largely, and carers could apply for it, and it went out really quickly, because I think the thinking was that this money was really needed urgently, and that the carers centres were best placed to deliver it urgently. And it was gone very, very quickly.
Okay, and we see again, just looking through your statement, in paragraph 20, you say that the Scottish Government were looking into a carer strategy, and you discuss that in paragraph 20. I don't need to dwell on that. And we see at paragraph 22 that the Distance Aware scheme was introduced in January 2022, and you don't have any details of what it is, but I presume that Distance Awareness scheme, was that for people to be aware of how close they were to each other? Is that broadly speaking what it was about?
Well, it was at the time when things were kind of easing up in terms of the protective measures. So so people were able to, there wasn't so much legislation around going out and keeping a distance and wearing masks and so on. But the thinking was that to recognise that there were people more vulnerable, that they could wear a lanyard or a badge to say, you know, stay 2 metres away from me because I'm vulnerable. And it provoked a lot of anger. I certainly felt angry about it because I felt that what should be happening is that everybody should be taking the measures to keep everybody safe rather than having people to take that kind of personal responsibility and single themselves out as being vulnerable. And in reality, practically nobody knew what this distance aware scheme was. They didn't know what these lanyards meant. The badges were tiny. If you were going to read the badge, you'd have to be up close to somebody. And it just felt like that was another kind of token measure to say, well, we're taking away the protective measures, but here's something that you can use to keep yourself safe. But actually, it wasn't going to work in practice. Okay.
And you talk about that, and then you move on in your statement to paragraphs 24 and 25, that in February 2022, the group raised concerns about the Scottish Government carers strategy. And am I correct that one of the principal concerns was the lack of services not having been reopened by 2022? Is that right?
Yeah, well, that was certainly one of the concerns, and so I'm just going on.
And I think that's what prompted the meeting with Hamza Yousaf. You mentioned that, who was the Cabinet Secretary at the time. Is that fair to say? And I think we've already heard your evidence in that, so we don't need to hear it again. But am I correct? That arose out the carers strategy.
Well, the meeting with the Cabinet Secretary, that came about really through the coalition of carers, and some of it was kind of linked because, you know, because we are 3 unpaid carers from the coalition of carers collaborative group who were attending the pandemic response group. We would go back and feedback issues to that carers collaborative group, and there were quite a number of issues. It wasn't just about the lack of opening of services. It was things like the fact that people were still being charged for support, even if that support wasn't actually there, or people couldn't use the support, and people's concerns about the, I won't call them restrictions because they're more like protections, but there were lots of concerns about the protective measures being lifted. I had particular concerns about my husband and his condition, because Parkinson's, for some strange reason, wasn't included in the list of high-risk conditions. So people with Parkinson's weren't in the shielding list. They weren't offered the support that people were provided when they were shielding. They weren't given priority for vaccines. Well, I know that Parkinson's UK and Scotland were really saying that people with Parkinson's were clearly at risk, particularly with advanced Parkinson's, because of the respiratory issues, the swallowing difficulties, and so that was, you know, it's a whole range of issues really that we wanted to raise with the Cabinet Secretary.
Can I just, just as a general question, because you go on to paragraph 28 to tell us a further meeting was arranged, this time with the Deputy Chief Medical Officer, although that was cancelled. Just as a general proposition, without going into details of the particular discussions or the particular meetings, did you feel that the public bodies, such whether it be the Chief Medical Officer, whether it be the Scottish Government or the local authorities, did you feel that they were listening to the care group at these meetings?
I think not enough. There were 2 meetings with the Deputy Clinical Medical Directors or Officers arranged. One was through the Coalition of Carers, and that one actually happened. And the other one was through the Pandemic Response Adult Social Care Group, and that one didn't happen because we were told that there was too much pressure on diaries, and there was annual leave, which you imagine didn't go down very well with us unpaid carers who haven't had a holiday for a long time. But we put our questions to the questions that came from the Pandemic Response Group. We put down in writing, and we got answers back but the meeting that we had with through the coalition of carers, we did actually have a meeting, and we asked for something back in writing, and we did get something back in writing. So I think we were listened to, and I think we got answers, but it very often felt as if the answers were just kind of stock answers that didn't actually change anything. So I think it was once again an experience of raising the issue, saying what we thought, but just feeling that it didn't actually change anything.
Well, I think maybe the answer to my question maybe lies in your statement itself, because if I understand you correctly, what you're saying in paragraphs 42 and 43 is that one of the group's concerns was that the Scottish Government was more concerned about getting the economy back up and running than the vulnerable members of society. Have I properly narrated your position in those paragraphs?
Yes, yeah, I think that's just the way it was. One of the questions that we had, and we asked the clinical medical, the deputy clinical medical, I can't remember if it's director or officer now, but was about whether there'd been an equality impact assessment, you know, of as protective measures were being lifted, and it took a while to get an answer to that. But then in one of the responses that we got back, there was actually a link to the equality impact assessment, and I've actually, just the way that it ended, it says, insofar as these mitigating actions may not be able to mitigate all of the potential impacts, the Scottish Government currently considers the potential impacts justified. And as I read that equality impact assessment, and I read it again today, it was really based on the fact that they were removing many of the requirements for people to take these protective actions, but it was on the expectation that there'd be a lot of guidance to people to still keep them in place and to recognise that there were really vulnerable people out there, and it was based on the expectation that people would still be wearing masks and where required, and still keeping 2 metres apart, and of course the reality is once you've removed the requirement, people just went back, many of them did, to how things were before. And the equality impact assessment was really about vulnerable people taking personal responsibility for keeping themselves safe. Well, people can't, they can't take personal responsibility for keeping themselves safe because that depends on other people. So to finish off saying that, recognising that they can't mitigate all of the potential impacts, but considering the potential impacts justified, I think what was really needed was action to protect the most vulnerable and to make sure that the most vulnerable were protected, rather than just acknowledging that we can't keep everybody safe, which is the way that reads, but it's justified.
I mean, just to, I suppose, summarise what I understand you're saying, you're critical, one of the other things you're critical of is the time taken by the Scottish Government to progress the carer strategy. Just as a general proposition, is that the time taken, would you say that it was too long? It was far too long. Right. Because we were really highlighting the need for urgent action, because and for it to be about carer recovery. And we were told, first of all, that it would be produced by the spring, and spring came and went. And then we were told it would be summer came and went, and in the end it was December before it was published. And really much focus on recovery in it. Can I ask, what were the consequences of the delay? Were there any negative consequences for carers? Yeah, what we were asking for was the carer, we asked that it be a carer recovery plan. We asked that it recognise that carers had been struggling for a long time, and carers' mental health had been affected. It was really traumatic. Carers' physical health had been affected. Often the conditions of the people they were caring for had been affected, and always with a lack of support. And before the pandemic, there was a lack of support. Throughout the pandemic, that got even worse. And so to have a year go by without any strategy to deal with that, and then when the strategy was published, we'd asked that it be short, sharp, because the draft strategy that came out was very lengthy, it was very comprehensive, but really it was a summary of what was already happening rather than new actions and how things were going to improve and who was going to monitor that and timescales.
So we were saying it needs to be short, it needs to be, or if you're going to have a big, a very comprehensive document, you also need to have something that focuses on carer recovery. These are the actions that we're taking, and these are the timescales, and this is how it's going to be monitored, and this is how it's going to be funded. And actually what came out was simply the big, full, comprehensive document that didn't have very many new actions in it.
Can I ask you maybe a question that maybe summarises your evidence, or summarises what I understand to be your statement? The care group and other groups like the Coalition of Carers, the Scottish Government involved them insofar as they were invited to meetings and so forth, but is it your evidence that generally you were there but you were almost a silent partner in terms of moving things forward? Is that essentially what?
Yeah, I mean, I think within the pandemic response group, I think we were heard, and I think we were, well, we said a lot, I think we were listened to. But actually in terms of...
But there's a difference between listening to somebody and acting upon what they're saying. I suppose that's my question. Were they listening to you? Were they acting upon what you were saying? Or were they listening to you and not acting upon what you were saying?
I think it was something to do with the structure as well. I think that the group maybe found it difficult to know how to act on what we were saying, because we had it was a complicated structure, because we had somebody from the Gold group coming and presenting, and that discussion seemed to be called the Silver Social Care Group. It seems odd, but that discussion seemed to be the Silver Social Care Group, and so that provoked discussions, and we assumed then that what we were saying would go back to the Gold group. But I have no idea who was on the Gold group, and I have no idea if anything that we said or the group said went back to that Gold group, or anything, or how that was going to be acted on. So it didn't feel really two-way. It just felt we were having these discussions, we were raising issues, we were agreeing on issues, and sometimes there were actions that were taken forward. But it felt more like an information sharing group than a group that was able to change anything. And as unpaid carers on that group, we felt even less able to change anything really.
So I think, to summarise, come to your closing copes for the inquiry. To summarise, you were there and being listened to, but you didn't feel that you were influencing the Scottish Government. They weren't being persuaded or changing things because of what was being said. Is that just a fair way to sum it up?
I think it is, yeah. And I think there's a commitment from the Scottish Government to to have a partnership approach and to involve people in these policy developments. But actually, I think there's a lot to learn really about how to do that in practice, because I think if you're asking people to give up their time, and it was a considerable amount of time, we put a considerable amount of effort into our attendance in these groups and contributed a lot. But if you're asking people to do that, then I think what's said, what the members of the public who are involved in that way need to have a right to expect is that what they say is really prioritised and given importance and acted upon. And the fact that the Gold Group didn't have unpaid carer representatives, I think says a lot too. It didn't feel as if it was going anywhere. It's like talking in a void.
The toothless tiger.
Would it be fair to say, if I might interrupt,
Sorry,
that you were listened to, you accept that, but as you've already said, nothing seemed to come of that. If the persons that were the recipients or listened to what you were saying decided that they didn't agree with what you were saying, for example, you couldn't really have any complaint if they had come back to you subsequently and said, well, for reasons A, B and C, we're not going to accept what you said there. I think you'd probably agree that would be a reasonable thing to do. You may not agree with them, but it'd be reasonable. But what you were doing was you were offering your advice, your experience, the information that you had to give them, and they went away, didn't do anything about it, and didn't explain to you or tell you why they weren't doing anything about it.
Yeah, that's right. It would have been good to maybe have had minutes of the Gold Group, so that we could have seen where our discussions went, to see what was discussed, why maybe things weren't agreed with or couldn't happen, and to have that, because at least then we'd be informed. But it didn't feel like that at all. It just felt like it didn't go anywhere.
I see that. And your point is a valid one, I would have thought, that may be particularly potent when the people that are offering their advice, information, and so forth are unpaid volunteers who are giving up their time. And one would imagine didn't want to give up their time for nothing, for no purpose.
Yeah, it was often really quite challenging for us to, you know, to be able to get out with the meetings. We were arranging to meet with each other and catch up with each other and putting things down in writing, and you know that all takes time when you're, because we all of us had substantial caring roles throughout this, so that was all hard. And looking back, you know, I think it was probably worth it on balance, you know, but only just.
All right, good, thank you. Sorry, Mr. Dunlop.
No, I just, that was very useful, Millard, and I'm grateful. We have the hopes for your inquiry, and I won't repeat your statements before the inquiry. I suppose just before thanking you for your time, Mrs. Purchase, I just wonder if there's anything you would like to tell us that's relevant to the inquiry that isn't either dealt with in your statement or you haven't dealt with in your oral evidence before us today.
I don't think there's anything that isn't included in the evidence. You know, it's good that the inquiry's happening, and I hope that there are lessons learned, because it was very traumatic for so many people, and I think really the way forward would be to make sure that when discussions are happening, that the people who are going to be most affected by these discussions are involved at every level, including at the highest level, because it does feel still as if at the highest level, you know, I mean, I don't know who was involved in those really high level meetings, but there should be a transparency around that, and there should be a partnership approach all the way up and all the way down.
Thank you, Mrs. Purchase, and thank you for your time and assisting us with preparing such a helpful statement. Well, as you know, there are no further witnesses this afternoon.
No, very good, thank you. Yes, thank you, Mrs. Purchase. I'm very grateful for you.
Thank you very much. Thank you.
That brings an end to the proceedings for today. Back on Tuesday. I don't know, are you back next week, Mr. Dunlop?
No, I'm not. I'm not in at all next week, which I understand is the last week of the impact hearing evidence in relation to Portfolio 3. So,
thank you for your assistance in the parts that you took part in.
Not at all. Thank you for your kind words.
Very good. Tuesday morning then. Thank you very much. At 9:45, I should say.
Thank you.